and I hope we have some information to share with you this morning that will be useful. I'm Bill Abraham from The Ohio State University, and it gives me great pleasure to chair this symposium on ReDS guided management of pulmonary congestion. Let me first tell you a little bit about ReDS technology. ReDS is based on see-through-the-wall technology, first developed by the military and ultimately miniaturized and applied to medicine. So this is a miniature radar technology that passes through the lung and provides a direct and quantitative assessment of lung fluid content. The measurement is absolute, and by that I mean we get a measurement of true lung fluid content in absolute terms. We derive this from a focused electromagnetic radar beam through the right lung. We know, based on studies using the gold standard of computed tomography of the lung, and also then using ReDS, that the normal lung is comprised of about 20 to 35% fluid content. So that is the target range for treating heart failure patients. The measurement takes about 45 minutes, and you can put the device on top of clothes. It doesn't require skin contact. And here is the ReDS point of care lung fluid management system. You can see that it's on wheels. There's a console. There's essentially a clip or harness that goes over the shoulder to position the emitter and receiver. And it's quite user-friendly, and again, only takes a matter of seconds to take a measurement in the clinic or in the home. As I mentioned, it has been validated against the gold standard of computed tomography for assessing the fluid content in a tissue, in this instance in the lung. And you can see the published data here demonstrating a very strong correlation between ReDS fluid assessment and that assessed using computed tomography. There are 356 data points here from phantoms, from animals, and from humans with various degrees of wetness or dryness of the lungs. And you'll see the very tight correlation with an interclass correlation coefficient of 0.94. Now, how do we interpret ReDS data to manage heart failure patients? Well, it really is quite easy, and this scheme was devised by Sanjay Dadamani and colleagues at the Geisinger Clinic, but I think it's quite informative in its simplicity. And you think about this simply as a meter of lung wetness or dryness, and again, this range of about 20 or 25 to 35% is considered normal or ideal, and the lung may get wetter, implying hypervolemia and pulmonary congestion. Or maybe we overshoot with our diuretics and the lung gets too dry, and we can move the needle back into the desired range, the green range, by either increasing or decreasing our doses of diuretics. It really is that simple. And when you think about the time course to heart failure decompensation, and you've all seen this slide or a slide that looks like it before, this is adapted from a widely cited paper from Phil Adamson, showing the time course to heart failure decompensation. The earliest physiological changes which can be detected are increases in intracardiac and pulmonary artery pressure and increases in lung fluid content. And this is perhaps why CardioMEMS and ReDS are emerging as two of our most favorable technologies for guiding the management of heart failure patients. Now, you've seen me, some of you have seen me present this before. These are what I believe are the prerequisites for success in a monitoring system. You have to measure the appropriate signal here, either pressure or fluid content. The measurement must be accurate. I think measuring absolute values is critically important, because when we measure only relative change, when we know if the lung is wetter or drier, but we don't know when it's normally dry, it's difficult to make treatment decisions. So the information has to be actionable, and we need to wrap treatment algorithms around it, such as the one that you saw on the prior slide from Geisinger, in order to improve patient outcomes. The bottom line is if you don't use it, you can't improve patient outcomes. This is a monitoring device, not a directly therapeutic device. You have to use the information. And at least to my knowledge, there are only two technologies that meet all of these requirements in today's world, and that is ReDS and implantable hemodynamic monitoring devices such as CardioMEMS. So today we're going to talk about the use of ReDS across the continuum of care, from the emergency department to the heart failure floor to discharge, in the outpatient clinic and in the home, and in skilled nursing facilities. And in order to do that, we have brought together really an all-star lineup of speakers who have done the fundamental research with ReDS in these various point-of-care settings. Frank Peacock, who is studying ReDS in the emergency department. Christopher Chen, who is also looking at the use of ReDS in the emergency department. Sean Pinney, who's done some studies at discharge and in the outpatient clinic, and Scott Feitel, who is experienced with the use of ReDS in the clinic and during home visits, and Dan Ben-Simone, who has studied ReDS across this continuum of point of care. So we've got an aggressive agenda. I think we've allotted about 8 minutes to each speaker, so guys, you got to talk fast, but convey the information well. And we're going to present in the order shown on this slide. For time's sake, I'm not going to come up between each speaker, so please just come up in series. Dan Ben-Simone, Frank Peacock, Christopher Chen, and Scott Feitel. So Dan, let's get you up here and get started. And thank you also very much for joining us this morning.